Chapter 33. So what's it like to be on lithium? My experience is that going on lithium was not the end of the world. In fact, in some ways it was the beginning of a new one, where I was no longer at the mercy of the peaks and troughs of bipolar disorder. Lithium made me feel held, like there was something solid under my feet and something holding me steady at last. It did not cure all my problems, but it did give me a platform from which to start facing them. Did it blunt me emotionally? Yes, to a certain extent it did, but by the time I'd reached this point, I wanted blunting. Lithium meant that I no longer felt I would die from sadness or explode with madness. I was grateful to get off the roller coaster. The blunting applied also to my creativity, though, and I had mixed feelings about this. I went from the endless creative sparking and sparkling of mania to feeling completely disconnected from that part of myself. But it quelled the almost painful intensity of that drive, so, I reasoned, maybe it was okay to lay it to rest for a while. Lithium is very effective at controlling the highs of mania, but not quite so effective with the lows. I continued to suffer a milder form of depression for most of the time I was on the drug, although from the places I had been, I mistook low-grade depression for pure happiness, so I never really questioned it. After the toxicity episode, though, I began to consider how for many people, once a medication regime is established, stabilised and judged to be having some good effect, and the judge may be the patient, but often it is the doctor, a person can remain on these regimes unchanged for years. A diagnosis is rarely revisited unless to be upgraded in the face of crisis. It is rarely downgraded, and there has been a reluctance to accept that people can and do recover, and that medications used in the acute stages of illness may not be suitable as the person seeks a progression towards wellness. I had to learn how to be responsible with taking lithium, and this was good practice for my later attempts at getting clean. I had to accept that if I wasn't going to take it as prescribed, there was no point in taking it at all, and that if I was going to mess with it, it could make me seriously ill in a way that I might not come back from, in a way that certainly wasn't going to make me feel any better about where my life had ended up. Want to feel really bad about stuff? Try being in a coma or being brain damaged and in a wheelchair for the rest of your life. These were the grim scenes that the psych nurses painted for me, and it worked. I became a compliant medication taker. That was a first. Stopping lithium after 14 years was a big deal. It signified the removal of a large safety net from underneath me. I was scared of what might happen if I wasn't taking it anymore. The rampant highs and psychotic lows of my past held no attraction. But as the months went by and the ritual of blood tests and monitoring began to dwindle, I became aware of a growing sense that I was attaining another level of freedom. Lithium had tied me to the mental health system and to my status as a patient. The blood tests always fed back to the doctor the information that I'd been taking the medicine as I should. If my blood test had ever revealed that I wasn't, this would have been ammunition for a compulsory treatment order. An outpatient compulsory treatment order in practice means that a community psychiatric nurse can visit your home as deemed necessary and either supervise you taking the medicine or deliver it via injection. An inpatient CTO means that you are sectioned, committed, to a psychiatric hospital to make sure you comply with the order. A CTO is a very powerful tool and takes away the patient's right to any partnership in medication choices and decisions. The doctor becomes king. Andrew was deemed to be non-compliant with medication. As an outpatient, a male psychiatric nurse armed with a CTO and a syringe would show up at his home once a month and give him an injection of powerful antipsychotic medication into his buttock. For the next week or so he would be zombied, listless and depressed. As the medication gradually wore off, these emotions would become compounded with a profound irritability, blackness and anxiety about the state of the world. Then it would be time for the next shot. It was devastating to watch him become lost in this endless cycle, crushing his creativity, his hope and his future, and replacing his innately gentle personality with that of an angry and dispirited young man. Andrew's depth of anguish, humiliation and powerlessness over this process completely overshadowed any possibility that the drugs might do any good. Instead, the enforced medication hastened his decline into hopelessness and despair. He bitterly resented the psychiatrist's control over him, based as it was upon perceptions of him and his behaviour that he believed were subjective and based on misunderstandings. As I've heard people close to him say, Andrew encountered the mental health system for help with depression, and somehow he came out with schizophrenia, an increasingly dark, grim outlook on life that he never overcame. Did the endless round of legally enforced committals and coerced use of antipsychotics assist him in improving his mental health in any way? Those of us watching on thought not. This was no healing partnership. Andrew's treatment regime seemed based upon power and control, the enforcement of the beliefs of those who thought they knew what was best for him, based on the fact that his father had committed suicide. No doctor wanted Andrew to kill himself on their watch, which lasted for almost 20 years. Ironically, his death in July 2007 was not a suicide, but he was still trying to walk away, literally, from the system when it happened. The Wellington Coroner's Court report was eventually released 3 years after Andrew's death and was critical of both police and Capital Coast DHB. He disappeared from the day program at Kenepuru Hospital after a 3-month inpatient admission. According to family members, the day program consisted of a group of male patients sitting around in a small room staring into space, soul-destroying but not uncommon practice. Andrew, who we can be sure would have hated that, took his Bible and went for a walk and never came back. No search was initiated for him until 3 weeks later when police and family intervened, their missing persons calls having garnered no response. Andrew's body was found by police in a creek on the hospital grounds, not far from the ward, 19 days after he disappeared. His death was ruled accidental by way of hypothermia. The coroner's recommendation was that the hospital should put up a fence.